Tricuspid atresia is a type of congenital heart disease characterized by the complete absence or the abnormal development of the right atrioventricular valve. This means that the right ventricle is either too small or absent. In children that are born with tricuspid atresia, life is temporarily allowed by an atrial septal defect that must be surgically enlarged if it is restrictive. Tricuspid atresia can also be associated with transposition of the great arteries, and it is often associated with pulmonary stenosis and a ventricular septal defect. Other associated heart defects may occur as well. In children with tricuspid atresia, oxygen-poor blood mixes with oxygen-rich blood, and that causes the cyanosis. The degree of the cyanosis depends on the presence of a pulmonary stenosis or on the size of the ventricular septal defect. Patients with tricuspid atresia associated with a large ventricular septal defect but no pulmonary stenosis present increased pulmonary vascular markings and pulmonary hypertension. In patients with tricuspid atresia associated with severe pulmonary stenosis or a small ventricular septal defect, life is temporarily allowed by a patent ductus arteriosus. Children with tricuspid atresia associated with pulmonary stenosis, which is the most common form of tricuspid atresia, usually present severe cyanosis, while those children with a large ventricular septal defect and no pulmonary stenosis present mild cyanosis. Children with tricuspid atresia with a small atrial septal defect may present symptoms of heart failure and severe hepatomegaly. In those cases with pulmonary stenosis, a systolic murmur can be heard. Retarded growth and fatigue may occur as well. The most useful methods of diagnosis are electrocardiography, ECG, chest radiography, echocardiography, cardiac catheterization. Electrocardiography shows right atrial hypertrophy. Chest radiography may reveal no evidence of tricuspid atresia, or, according to the anatomical type, it may show a normal or small heart with pulmonary hyperperfusion or cardiomegaly with increased pulmonary vascular markings. Echocardiography usually allows a comprehensive diagnosis of tricuspid atresia. Apical four-chamber view. The mitral valve has a normal morphology. The tricuspid valve is atresic. The ventricular septum has two defects, a restrictive one, located superiorly, and a midventricular larger one. The right ventricular cavity is diminutive. Apical four-chamber view with color flow mapping. The mitral valve has a normal morphology. The tricuspid valve is atresic. The ventricular septum has two defects, a restrictive one, located superiorly, and a midventricular larger one. The right ventricular cavity is diminutive. Color flow mapping demonstrates the superior restrictive ventricular septal defect. Cardiac catheterization is needed in order to make a complete diagnosis. It may be useful in those cases in which the atrial septal defect must be surgically enlarged or when pulmonary vascular resistance needs to be measured. Prostaglandin therapy may be useful for infants who present a patent ductus arteriosus. Diuretic and digoxin therapy may be useful for patients who present heart failure and are waiting for surgery. Surgical repair for tricuspid atresia is performed to provide adequate blood flow to the lungs. There are two types of surgical treatment: palliative surgery and corrective surgery. 3 different palliative procedures may be performed for tricuspid atresia: atrial septostomy, shunting, and cardiopulmonary anastomosis. Atrial septostomy is the procedure of choice for symptomatic infants 3 or 4 months of age with a small atrial septal defect. The procedure enlarges the communication between the two atria in order to increase blood flow from right towards left. Palliative surgery for tricuspid atresia with pulmonary stenosis consists in the construction of a shunt, a connection, between the aorta and the pulmonary artery. This procedure is usually carried out during the first 6 to 8 weeks of life. Cardiopulmonary anastomosis, Glenn procedure, is usually carried out in children that are 6 months of age and can be performed only in children with mean pulmonary artery pressure less than 15 to 16 millimeters of mercury. Cardiopulmonary anastomosis is the most commonly performed palliative procedure. It consists in a direct connection between the superior vena cava and the right pulmonary artery in order to allow oxygen-poor blood to reach the lungs. The Fontan procedure is now the procedure of choice for tricuspid atresia. It is carried out between the 2nd and the 4th year of life in children with mean pulmonary artery pressure less than 18 millimeters of mercury. The procedure directly connects the two vena cava to the pulmonary arteries, thus creating a path for oxygen-poor blood to flow directly into the pulmonary arteries, which then carry the blood into the lungs. If an atrial septal defect occurs, the Fontan procedure involves its closure. The Fontan procedure diverts the venous blood to the pulmonary artery without passage through the heart. The superior and the inferior vena cava are disconnected from the right atrium, and then the superior vena cava is directly redirected into the pulmonary artery, while the inferior vena cava is connected to the pulmonary artery by placement of a conduit. The operation is a staged procedure. Firstly, if the pulmonary artery is not fully closed, it must be surgically sectioned and then sutured, as the animation shows. The superior vena cava is now disconnected from the right atrium, which is then closed by using a continuous suture. Then, the distal end of the superior vena cava is connected to the right pulmonary artery with a proline continuous suture. In the end, the inferior vena cava is detached from the atrium. The atrium is closed, and the inferior vena cava is connected to the right pulmonary artery with placement by suture of an external Gore-Tex conduit. The animation shows here the external conduit. Patients who present high pulmonary pressure should undergo the so-called fenestration that involves the construction of a communication between the conduit and the right atrium.